The following podcast will discuss chest pain, specifically ruling out acute coronary syndrome. Mr. Thomas is a 56-year-old male presenting with intermittent substernal chest pressure for the past 3 days. Chest painers can be tricky, especially when ruling out acute coronary syndrome. Sometimes it can be hard to risk stratify them. So what do we do with Mr. Thomas? Our initial steps are the usual. Remember your OPQ, RST, your onset, your provocation and relieving factors, your quality, your radiation, your severity, and your timing. Next, a quick review of symptoms, particularly those pertinent to chest pain, such as shortness of breath, nausea, dizziness, weakness, cough, and abdominal pain. Don't forget your chest pain risk factors, including hypertension, hyperlipidemia, diabetes, family history of coronary artery disease, tobacco, and of course, being male. Next, look at your vital signs. Abnormal vitals should increase your concern. Then, a physical exam, particularly your cardiovascular, pulmonary, abdominal, and general. Next, get your EKG. Is this a STEMI? Is the most important question you're asking yourself. With your history and physical, you should be able to risk stratify your patients into a couple of categories, from low to high. In your high-risk categories, you've got your STEMI. Your STEMI is one of your easiest dispositions. Done, cath lab. Next, you've got your high-risk patients. These patients often have a history of coronary artery disease or a concerning story, such as crushing substernal chest pressure, shortness of breath, diaphoresis. These will often need admission because they're too high risk for ED observation or outpatient stress. Next, you've got your moderate risk patients. These patients have risk factors with a good story, or at least a concerning story. These patients will usually stay in the department for 2 troponins and an AM stress test. However, some of them will be admitted. Next, you've got your low-risk patients. These are generally patients with few risk factors and a concerning story, and a non-concerning story. They generally have atypical pain. Often you'll get 2 troponins, plus or minus an outpatient stress, although sometimes you'll just have the patient follow up with their primary doctor for referral. Then you've got your super low patients. These patients have no risk factors. They're super young, like in their 20s. Their pain is atypical, and they often have a better alternative diagnosis, such as bronchitis, URI, or costochondritis. These patients do not get troponins. It's a bit of an art, and every attending has different thresholds for which category they place patients in, so keep in mind, depending on which attending you work with, the plan will change. Just remember, you're learning different styles, so you can figure out your own. So, you already have in your head what kind of risk stratification you're putting Mr. Thomas in. Now it's time for your orders. Remember, you always start with IVO2 monitor, aspirin for anyone getting troponins. Next, treat the pain with nitro, sometimes morphine. For your labs, get a CBC, BMP, maybe tropes. Get your chest x-ray, and of course, if you haven't already, get your EKG. Let's talk about our differential. Your differential includes your cardiovascular complaints such as ACS, aortic dissection, pericarditis, arrhythmia, myocarditis. You've got your respiratory system, pulmonary embolism, pneumonia, pneumothorax, bronchitis, asthma, COPD. You've got GI, such as GERD, hiatal hernia, or Boerhaave syndrome. And you've got psych, such as anxiety. This list is not all-inclusive, and remember, you're ruling out the emergencies, such as ACS, aortic dissection, PE, pneumonia, pneumothorax, Boerhaave syndrome. This is the most important thing, is to rule out the scary stuff, and then, if you've got a better diagnosis, run with it. So, last is your disposition. What do we do with Mr. Thomas? This all goes back to your risk stratification. STEMIs, go to the cath lab. That's easy. You might admit a patient to the CCU for NSTEMIs with elevated troponins or people with abnormal stress tests. You might admit them to telemetry for your general chest pain rule-out admissions, or you might send them home. It just depends on the risk and the test results.